Mobility is essential for activities of daily living and recreational activities. Many functions of the body depend on mobility. Intact musculoskeletal and nervous systems are necessary for mobility and function. Nursing practice related to mobility and immobility requires the incorporation of science, nursing knowledge, and clinical skills to provide competent care. Movement requires coordination between the musculoskeletal and nervous system. Nurses must pay attention to body mechanics to avoid injury to patients and theirself. Body mechanics are the coordinated efforts of the musculoskeletal and nervous system. Nurses use information about body mechanics when implementing nursing interventions, such as positioning patients, determining a patient's risk for falls, and selecting the safest way to move or transfer patients. Alignment and balance, or posture, refer to the positioning of joints, tendons, ligaments, and muscles while standing, sitting, or lying. Body alignment means that the individual's center of gravity is stable. Without balance control, the center of gravity is displaced. Individuals require balance for maintaining a static position, sitting, and moving, such as walking. Disease, injury, pain, physical development, and life changes compromise the ability to remain balanced. Medications that cause dizziness and prolonged immobility can also affect balance. Impaired balance is a major threat to mobility and physical safety and contributes to a fear of falling and self-imposed activity restriction. Weight is the force exerted by gravity. The force of weight is always directed downward. This is why an unbalanced object falls. People's center of gravity are usually at 55% to 57% of standing height or in the midline, which is why only using principles of body mechanics in lifting patients also leads to injury of the nurse or healthcare professional. The greater the surface area of the object that is moved, the greater the friction. Large objects produce greater resistance to movement. This is why nurses need to be aware of the friction that can cause a patient's skin to shear or tear. The force exerted against the skin while the skin remains stationary and the bony structures move is called shear. Bones are important for mobilization because they are firm, rigid, and elastic. The aging process changes the components of bone, which impacts mobility. Firmness results from inorganic salts such as calcium and phosphate that are within the bony matrix. It is related to the rigidity of the bone, which is necessary to keep long bones straight and enables bones to withstand weight bearing. Elasticity and skeletal flexibility change with age. Bones store calcium and release it into the circulation as needed. Patients with decreased calcium regulation and metabolism and immobility are at risk for developing osteoporosis and subsequent pathological fractures. In addition, the internal structure of long bones contain bone marrow, which participates in red blood cell production and acts as a reservoir for blood. Patients with altered bone marrow function or diminished red blood cell production fatigue easily because of reduced hemoglobin and oxygen carrying ability. This fatigue decreases their mobility and increases the risk of falling, which impacts a patient's mobility status. Joints are the connection between bones. Each joint is classified according to its structure and degree of mobility. There are 3 classifications of joint: fibrous, synovial, and cartilaginous. Ligaments are white, shiny, flexible bands of fibrous tissue binding joints together and connecting bones and cartilage, and they aid joint flexibility and support. Tendons are white, glistening, fibrous bands of tissue that connect muscle to bone and are strong, flexible, and inelastic. Cartilage is non-vascular, supporting connective tissue that is located chiefly in the joints in thorax, trachea, larynx, nose, and ear. The characteristics of the cartilage change with the aging process. Movements of bones and joints involves active processes that are carefully integrated to achieve coordination. Skeletal muscles, because of their ability to contract and relax, are the working elements of movement. Anatomical structure and attachment to the skeleton enhance contractile elements of the skeletal muscle. The nervous system regulates movement and posture. The precentral gyrus, or motor strip, is the major voluntary motor area and is in the cerebral cortex. A majority of motor fibers descend from the motor strip and cross at the level of the medulla. Movement is impaired by disorders that alter neurotransmitter production, transfer of impulses from the nerve to the muscle, or activation of muscle. Congenital or acquired postural abnormalities affect the efficiency of the musculoskeletal system and body alignment, balance, and appearance. During assessment, observe body alignment and range of motion. Postural abnormalities can cause pain, impair alignment, or mobility, or both. Knowledge about the characteristics, causes, and treatment of common postural abnormalities is necessary for lifting, transferring, and positioning patients. Injury and disease lead to many alterations in musculoskeletal function. Damage to any component of the central nervous system that regulates a voluntary movement results in impaired body alignment, balance, and mobility. Trauma from a head injury, ischemia from a stroke or brain attack, which is also known as cerebral vascular accident, CVA, or bacterial infections such as meningitis can damage the cerebellum or the motor strip in the cerebral cortex. Damage to the cerebellum causes problems with balance, and motor impairment is directly related to the amount of destruction of the motor strip. Trauma to the spinal cord also impairs mobility. Direct trauma to the musculoskeletal area can cause bruises, contusions, sprains, or fractures. Treatment often includes positioning the fractured bone in proper alignment and immobilizing it to promote healing and restore function. Even this temporary immobilization results in some muscle atrophy, loss of muscle tone, and joint tissue or joint stiffness. You need to know how to apply scientific principles in the clinical setting to determine the safest way to move patients and to understand the effect of immobility on the physiological, psychosocial, and developmental aspects of patient care. To determine how to move patients safely, assess their ability to move. Think of mobility as a continuum, with mobility on one end, immobility on the other, and varying degrees of partial immobility between the endpoints. Some patients move back and forth between mobility and immobility, but for others, immobility is absolute and continues indefinitely. Manual lifting and transferring patients contributes to the high incidence of work-related musculoskeletal problems and back injuries in nurses and other healthcare staff. Bed rest is an intervention that restricts patients to bed for therapeutic reasons. Nurses and healthcare providers most often prescribe this intervention. The effects of muscular deconditioning associated with lack of physical activity are often apparent in a matter of days. This cluster of symptoms is also often referred to as the hazards of immobility. The individual of average weight and height without a chronic illness on bed rest loses muscle strength from baseline levels at a rate of 3% a day. Immobility also is associated with cardiovascular, skeletal, and other organ changes. The term disuse atrophy describes the tendency of cells and tissue to reduce in size and function in response to prolonged inactivity resulting from bed rest, trauma, casting, or local nerve damage. Periods of immobility or prolonged bed rest cause major physiological, psychosocial, and social effects. These effects are gradual or intermediate and vary from patient to patient. The patient with complete mobility restrictions is continually at risk for the hazards of immobility. When possible, it is imperative that patients, especially the older adults, have limited bed rest and that their activity is more than bed to chair. The deconditioning related to reduced walking increases the risk for patients' falls. The severity of the impairment depends on the patient's overall health, degree and length of immobility, and age. The endocrine system, made up of hormone-secreting glands, maintains and regulates functions such as the response to stress and injury, growth and development, reproduction, maintenance of the internal environment, and energy production, use, and storage. When energy or stress occurs, the endocrine system triggers a series of responses aimed at maintaining blood pressure and preserving life. It is important in maintaining homeostasis. Immobility disrupts normal metabolic functioning, decreases the metabolic rate, altering the metabolism of carbohydrates, fats, and proteins, causing fluid, electrolyte, and calcium imbalances, and causing gastrointestinal disturbances, such as decreased appetite and slowing of peristalsis. In the presence of an infectious process, immobilized patients often have an increased basal metabolic rate as a result of a fever or wound healing because these increase cellular oxygen requirements. When the patient is immobile, his or her body often excretes more nitrogen, the end product of amino acid breakdown. Then it digests proteins, resulting in negative nitrogen balance. Weight loss, decreased muscle mass, and weakness result from tissue catabolism, or the breakdown of tissue. Immobility causes the release of calcium into the circulation. Normally, the kidneys excrete the excess calcium. However, if the kidneys are unable to respond appropriately, hypercalcemia results. Pathological fractures occur if calcium resorption continues as the patient remains on bed rest or continues to be immobile. Impairments of gastrointestinal functioning caused by decreased mobility vary. Difficulty in passing stools or constipation is a common symptom, although pseudodiarrhea often results from a fecal impaction, which this is the accumulation of hardened feces. Over time, intestinal function becomes depressed, dehydration occurs, absorption ceases, and fluid and electrolyte disturbances worsen. Lack of movement and exercise places patients at high risk for respiratory complications. Patients who are immobile are at high risk for developing pulmonary complications. The most common respiratory complications are atelectasis and hypostatic pneumonia, which is the inflammation of the lung from stasis or pooling of secretions. Both decrease oxygenation and prolonged recovery add to the patient's discomfort. In atelectasis, secretions block a bronchial or a bronchus and the distal lung tissue, the alveoli, which collapse as the existing air is absorbed, producing hypoventilation. The site of the blockage affects the severity of atelectasis. Sometimes an entire lung lobe or a whole lung can collapse. At some point in the development of these complications, there is a proportional decline in the patient's ability to cough productively. Ultimately, the distribution of mucus into the bronchi increases, particularly when the patient is in the supine, prone, or lateral position. Mucus accumulates in the dependent regions of the airways. Hypostatic pneumonia frequently results because mucus is an excellent place for bacteria to grow. Orthostatic hypotension is a drop of blood pressure greater than 20 millimeters of mercury in systolic pressure or 10 millimeters of mercury in diastolic pressure, and symptoms of dizziness, lightheadedness, nausea, tachycardia, and fainting when the patient goes from a supine to a standing position. In the immobilized patient, decreased circulating fluid volume, pooling of blood in the lower extremities, and decreased autonomic response can occur. These are especially evident in the older adult. As the workload of the heart increases, so does its oxygen consumption. Therefore, the heart works harder and less efficiently during periods of prolonged rest. As immobilization increases, cardiac output can fall, further decreasing cardiac efficiency and increasing workload. Patients who are immobile are also at risk for thrombus formation. A thrombus is an accumulation of platelets, fibrin, clotting factors, and the cellular elements of the blood attached to the interior wall of a vein or artery, which sometimes can include the lumen of the vessel. 3 factors contribute to venous thrombus formation: damage to the vessel wall, such as during a surgical procedure, alteration of blood flow, if a patient is on prolonged bed rest and has decreased venous return, and alterations in blood constituents, such as increased platelet activity. These 3 factors are often referred to as Virchow's triad. The effects of immobility on the musculoskeletal system include permanent or temporary impairment or permanent disability. Restricted mobility sometimes results in loss of endurance, strength, and muscle mass, and decreased stability and balance. Other effects of restricted mobility affecting the skeletal system are impaired calcium metabolism and joint mobility. Because of protein breakdown, the patient loses lean body mass. The reduced muscle mass is unable to sustain activity without increasing fatigue. If immobility continues and the patient does not exercise, there is further loss of muscle mass. Muscle weakness always occurs with immobility, and prolonged immobility often leads to disuse atrophy. Muscle atrophy is a widely observed response to illness, decreased activity of daily living, and immobilization. Loss of endurance, decreased muscle mass and strength, and joint stability put patients at risk for falls. Immobilization causes 2 skeletal changes: impaired calcium metabolism and joint abnormalities. Because immobilization results in bone resorption, the bone tissue is less dense or atrophied, and disuse osteoporosis can result. When disuse osteoporosis occurs, the patient is at risk for pathological fractures. Approximately 80% of people who have osteoporosis are female. Although primary osteoporosis is different in origin from the osteoporosis that results from immobility, It is imperative for nurses to recognize that immobilized patients are at high risk for accelerated bone loss if they have primary osteoporosis. A joint contracture is an abnormal and possibly permanent condition characterized by fixation of the joint. It is important to note that flexor muscles for joints are stronger than extensor muscles and therefore contribute to the formation of contractures. Disuse atrophy and shortening of the muscle fibers cause joint contractures. When a contracture occurs, the joint cannot achieve full range of motion. Contractures sometimes leave a joint or joints in a non-functional position, as seen in patients who are permanently curled in a fetal position. Early prevention of contractures is essential. One common and debilitating contracture is foot drop. When foot drop occurs, the foot is permanently fixed in the plantar flexion. Ambulation is difficult with the foot in this position because the patient cannot dorsiflex the foot. The patient with foot drop is unable to lift the toes off the ground. In the upright position, urine flows out of the renal pelvis and into the ureters and bladder because of gravitational forces. When the patient is recumbent or flat, the kidneys and ureters move towards a more level plane. Urine formed by the kidneys needs to enter the bladder unaided by gravity. Because the peristaltic contractions of the ureters are insufficient to overcome gravity, the renal pelvis fills before urine enters the ureters. This condition is called urinary stasis and increases the risk of urinary tract infections and renal calculi, or kidney stones. Renal calculi are calcium stones that lodge in the renal pelvis or pass through the ureters. Immobilized patients are at risk for calculi because they frequently have hypercalcemia. As the period of immobility continues, fluid intake often diminishes. When combined with other problems such as fever, the risk for dehydration increases. As a result, urine output declines on or about the 5th or 6th day after immobilization, and the urine becomes concentrated. This concentrated urine increases the risk for calculi formation and infection. Inappropriate perineal care after bowel movements, particularly in women, increase the risk of urinary tract contamination by E. coli bacteria. Another cause of urinary tract infections in immobilized patients is the use of an indwelling urinary catheter. The change in metabolism that accompany immobility aid to the harmful effects of pressure on the skin in the immobilized patient. This makes immobility a major risk factor for pressure ulcers. Any break in the integrity of the skin is difficult to heal. Preventing a pressure ulcer is much less expensive than treating one. Therefore, preventative nursing measures are imperative. A pressure ulcer is an impairment of the skin that results from prolonged ischemia or decreased blood supply to the tissues. The ulcer is characterized initially by inflammation and usually forms over bony prominences. Ischemia develops when pressure on the skin is greater than pressure inside the small peripheral blood vessels supplying blood to the skin. Tissue metabolism depends on the supply of oxygen and nutrients, too, and the elimination of metabolic waste from the blood. Pressure affects cellular metabolism by decreasing or totally eliminating tissue circulation. When a patient lies in bed or sits in a chair, the weight of the body is on bony prominences. The longer the pressure is applied, the longer the period of ischemia, and therefore the greater risk of skin breakdown. The prevalence of pressure ulcers is highest in long-term care facilities, with facility acquired being the highest in adult intensive care units. Illnesses that result in limited or impaired mobility can cause social isolation and loneliness. Patients with restricted mobility may have some depression, and we know that depression is an affective disorder that's characterized by feelings of sadness, melancholy, dejection, and worthlessness. It results from worrying about present and future levels of health, finances, and family needs. Because immobilization removes the patient from a daily routine, he or she has more time to worry about disability. Worrying quickly increases the patient's depression, causing withdrawal. Withdrawn patients often do not want to participate in their own care. Developmental changes tend to be associated with immobility in the very young and older adults. The newborn infant's spine is flexed and lacks the anterior-posterior curves of the adult. As the baby grows, musculoskeletal development permits support of weight for standing and walking. Posture is awkward because the head and upper trunk are carried forward. Because body weight is not distributed evenly along a line of gravity, posture is off balance and falls often occur. The infant, toddler, or preschooler is usually immobilized because of trauma or the need to correct a congenital skeletal abnormality. Prolonged immobilization delays the child's gross motor skills, intellectual development, and/or musculoskeletal development. The adolescent stage usually begins with a tremendous increase in growth. When the activity level is reduced due to trauma, illness, or surgery, the adolescents are often behind peers in gaining independence in accomplishing certain skills such as driving. Social isolation is a concern for this age group when immobilization occurs. When periods of prolonged immobility occur in adults, all physiological systems are at risk. In addition, the role of the adult often changes with regard to the family or social structure. Some adults lose their jobs, which affects their self-concept. A progressive loss of total bone mass occurs with the older adult. Some of the possible causes of this loss include decreased physical activity, hormonal changes, and bone resorption. The effect of bone loss is weaker, less dense bones. Often adults walk more slowly, take smaller steps, and appear less coordinated. Prescribed medications alter their sense of balance or affect their blood pressure, which can increase their risk of falls and injuries. The outcomes of a fall include not only possible injury, but hospitalization, loss of independence, psychological effects, and maybe even death. Older adults often experience functional status changes secondary to hospitalization and altered mobility status. Immobilization of older adults increases their physical dependence on others and accelerates functional losses. When providing nursing care for an older adult, encourage the patient to perform as many self-care activities as possible, thereby maintaining the highest level of mobility. Apply the nursing process and use a critical thinking approach in your care of patients. The nursing process provides a clinical decision-making approach for you to develop an individualized plan of care. When unsure of the patient's abilities, begin assessment of ability with the patient in the most supportive position and move to higher levels according to his or her tolerance. Usually the nurse assesses for and asks questions about the patient's degree of both mobility and immobility during the physical exam. You convey respect for the patient's preference, value, and needs when implementing the nursing process and designing a plan of care with the patient. Assessment of patient mobility focuses on range of motion, gait, exercise, and activity tolerance. Generally, the assessment of movement starts while the patient is lying and proceeds to assess sitting positions in bed, transfers to chair, and finally walking. This helps to protect the patient's safety. Range of motion is the maximum amount of movement available at a joint in one of the three planes of the body: sagittal, transverse, or frontal. The sagittal plane is a line that passes through the body from the front to the back, dividing it into a left and right side. The frontal plane passes through the body from the side to side and divides it into the front and back. The transverse plane is a horizontal line that divides the body into upper and lower portions. Ligaments, muscles, and the nature of the joint limit joint mobility in each of these planes. In the sagittal plane, movements are flexion and extension, dorsiflexion and plantar flexion and extension. In the frontal plane, movements are abduction and adduction, and eversion and inversion. In the transfer plane, movements are pronation and supination, and internal and external. When assessing range of motion, ask questions about and physically examine the patients for stiffness, swelling, pain, limited movement, and unequal movement. Range of motion exercises may be active, passive, or in between. Consider the medical plan of care and the patient's ability and need for assistance, teaching, or reinforcement before engaging in active range of motion exercises. Contractures develop in joints, not move periodically through their full range of motion. Assessment data from patients with limited joint movements vary based on the area affected. A flexion contracture of the neck is a serious disability because the patient's neck is permanently flexed, with the chin close to or actually touching the chest. Assessment reveals altered body alignment, changes in the visual field, and decreased level of independent functioning. One feature of the shoulder that sets it apart from other joints is that the strongest muscle controlling it is the deltoid, is in complete elongation in the normal position. No other muscle exerts its full strength when in complete elongation. Patients with limited movement in the shoulder have difficulty moving their arms. The elbow functions optimally at an angle of approximately 90 degrees. An elbow fixed in full extension is disabling and limits the patient's independence. Most functions of the hand are best carried out with the forearm in moderate pronation. When the forearm is fixed in a position of full supination, the patient's use of the hand is limited. The primary function of the wrist is to place the hand in slight dorsiflexion, the positioning of functioning. When the wrist is fixed in even a slightly flexed position, the grasp is weakened. The range of motion in the fingers and thumb enables the patient to perform ADLs and activities requiring fine motor skills. The functional position of the fingers and thumb is slight flexion of the thumb in opposition to the fingers. Because the lower extremities are concerned chiefly with locomotion and weight bearing, stability of the hip joint is more important than its mobility. Excessive abduction makes the affected leg appear too short, whereas excessive adduction makes it appear too long. In either case, the patient has limited locomotion and walks with an obvious limp. Internal and external rotation contractures cause an abnormal and unbalanced gait. A primary function of the knee is stability, which is achieved by range of motion, ligaments, and muscles. However, the knees cannot remain stable under weight-bearing conditions unless there is adequate quadriceps power to maintain the knee in full extension. An immobile knee joint results in serious disability. The degree of disability depends on the position in which the knee is stiffened. If it is fixed in full extension, the person needs to sit with the leg out in front. When the knee is flexed, the person limps while walking. The greater the flexion, the greater the limp. Without full range of motion of the ankle, gait deviations occur. If the joint is not stable, the person falls. When the person relaxes, as in a sleep or deep coma, the foot relaxes and assumes a position of plantar flexion. As a result, it becomes fixed in plantar flexion or foot drop, which impairs the ability to walk independently and increases the risks of falls. Extensive flexion of the toes results in clawing. When this is a permanent deformity, the foot is unable to rest flat on the floor, and patient is unable to walk properly. Flexion contractures are the most common foot deformity associated with reduced joint mobility. Assessing a patient's gait allows you to draw conclusions about balance, posture, safety, and the ability to walk without assistance. The mechanics of human gait involves coordination of the skeletal, neurological, and muscular systems of the human body. Nurses use exercise as therapy to correct a deformity or restore the overall body to a maximal state of health. Assessment of the patient's energy level includes the physiological effects of exercise and activity tolerance. Activity tolerance is the type and amount of exercise or work that a patient is able to perform. Assessment of activity tolerance is necessary when planning activities such as walking, range of motion, or ADLs. Tolerance assessment includes data from the physiological, emotional, and developmental domains. As activity begins, monitor patients for symptoms such as dyspnea, fatigue, chest pain, and/or changes in vital signs. A weak or debilitated patient is unable to sustain even slight changes in activity because of the increased demand for energy. When the patient experiences decreased activity tolerance, carefully assess how much time he or she needs to recover. Decreasing recovery time indicates improving activity tolerance. People who are depressed, worried, or anxious are frequently unable to tolerate exercise. Developmental changes also affect activity and tolerance. As the infant enters the toddler stage, the activity level increases and the need for sleep declines. The child entering preschool or primary grade expends mental energy in learning and often requires more rest after school or before strenuous play. The adolescent going through puberty requires more rest because much more body energy is expended for growth and hormone changes. Changes still occur through the adult years, but many of them are related to work and lifestyle choices. As the person grows older, activity tolerance changes. Muscle mass is reduced, and posture and bone composition changes. Changes in the cardiorespiratory system, such as decreased maximum heart rate and lung compliance, which affect the intensity of exercise, often occur. As age progresses, some older individuals still exercise but do so at a reduced intensity.